All right, looks like it is time for us to go ahead and get started here. Hello, everyone, and welcome to this month's Northwest ATTC webinar. I'm Jennifer Verbeck, and I'm your host for today. We're excited to have Michael and Desi Hite presenting for us today on crisis and hope, trends, risk assessment, and innovation in overcoming overdose. Next slide, please. We have a couple of quick housekeeping things. First, if you have any questions for our presenters, please type them into the chat box at any time, and we'll try to answer some as we go along and some at the end of the presentation. Next slide, please. You'll also be getting an email within the next day or two that has a link to a survey in it. Please take that survey. It helps us make sure we're bringing you the content you're interested in, and also helps us continue to offer free or low-cost events such as this one. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar, and that should be available on our website within the next couple of days. Next slide. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance, and it takes us about a week to get those out. You don't need to do anything to get the certificate unless you're watching this in a group. If that's the case, please have someone in the group email us within a business day with the names and email addresses for everyone who wants a certificate. And you'll see our email address up there on the slide. It's northwest@attcnetwork.org. Next slide. Okay, now on to our webinar. I'm pleased to introduce our speakers today. We have Michael Hite, who is a healthcare entrepreneur with a focus on technology to improve the treatment of challenging diseases. He has developed multiple pharmaceutical delivery technologies and is a named inventor on 13 US patents. Prior to founding Ayuda Medical, Michael was a co-founder and CEO of Impel Pharmaceuticals, a specialty company focusing on the treatment of central nervous system disorders. And we also have Dr. Desi Hite, a physician who is board certified in emergency medicine and is actively practicing in the state of Washington for over the last 13 years. She's a chief medical officer and co-founder of Ayuda Medical, which was founded in 2019. To bring emergency care closer to the patient and decrease the complications of overdose in the home setting. And then with that, I'll just go ahead and introduce them and they could take over and expand on that. Thank you.
Thank you very much. Appreciate it. Hello, everybody. Welcome to our talk. My name is Desi Hite, and today we're going to talk about crisis and hope, trends, risk assessment, and innovation in overcoming overdose. Before we begin, I'd like to offer a specific acknowledgement for the land from which we're joining you today, which is in Seattle, in King County, Washington. We at Ayuda Medical acknowledge that this is the traditional home of the Snoqualmie tribe and Makoshu tribe, and I want to take this opportunity to thank the original caretakers of this land who are still here. Now, a little bit about us. As you already heard, I'm a 13-year practicing physician, and Michael Hite has spent 20 years in device design and development. Together, we have co-founded Ayuda Medical with the focus on detecting medical emergencies in the home setting. Currently, Ayuda Medical is receiving funding from NIDA, the National Institute on Drug Abuse, via a Phase 2 award. We're working together to develop a wearable device to detect opioid overdose and alarm, so bystanders can become aware and act, hopefully in enough time to rescue. So a little bit about the topics we'll talk. I will talk in part 1 about opioids and overdose, as well as evolving trends over the last 5 years, especially as it relates to Region 10. We will talk about factors that increase the risk of fatal overdose. And then Mike will take over part 2, and he will speak about overdose education and intervention strategies, which includes new naloxones, devices, and mobile apps, as well as the challenges they encounter in being adopted. Finally, we'll end with our story at Ayuda Medical and a little bit about the lessons we learned. So let's talk about opioids and overdose. So a little bit about the terms opiate and opioid. So opiate are what we consider natural or derived from the opium poppy plant. That includes morphine. But opioid is the term we all use, which is any natural, semi-synthetic, or synthetic substance that acts on the opioid receptors. Now, endogenous opioids are synthesized by our bodies and they modulate pain and inflammation pathways. The opioid receptors can be found in the brain, spinal cord, and gut. And there are three types: mu, delta, and kappa. The mu receptors in the medulla are the ones that, whenever they're activated by opioids, will cause decreased breathing and lessen the body's response to low oxygen levels and high carbon dioxide levels. This leads to irregular and shallow breathing, apnea or pauses in breathing, and hypoxia. All of that is part of the fatal cascade in overdose. The symptoms that we see are pinpoint pupils, respiratory depression, and a decreased level of consciousness. We call that the opioid overdose triad. Now, a little bit about the substances we've heard about. So, the natural from the poppy plant are things like morphine and codeine that we use in cough suppression. Um, Morphine can be processed into semi-synthetic substances, which we often use, especially in the emergency department. That's oxycodone and hydrocodone, and their intravenous counterparts, oxymorphone and hydromorphone. And heroin is also synthesized from morphine. Now, synthetic medications are completely man-made. They include tramadol, methadone, which is often put in its own group, and fentanyl. So let's talk about fentanyl. Fentanyl is similar to morphine, but 100 times more potent. It is often used intravenously in surgeries, but is also easy to make and is now becoming increasingly pressed into pills, counterfeit pills, made to look like legitimate prescription opioids. It's so powerful that a tiny 2 milligram dose can be lethal, depending on a person's body size and tolerance. Yet, the DEA has found that counterfeit tablets can contain up to 5 milligrams of fentanyl per tablet, which is more than twice the lethal dose. Now, drug traffickers typically distribute fentanyl in kilograms. 1 kilogram has the potential to kill 500,000 people. So here's an example in King County, Washington, and you can see that the surge in overdose deaths over time is driven by fentanyl. In fact, fentanyl is found in 70% of overdose deaths. This graph shows that fentanyl-related deaths have spiked over time, while other opioid-related deaths have remained stable over the same period of time. Now, here's an example in Eugene, Oregon, and this was actually August 6, 2023, so just a couple weeks ago, and it was regarding a cluster of deaths that occurred due to contaminated substances. And here's the quote: "We have seen fentanyl contamination in cheap counterfeit pills sold as common medications, such as oxycodone, Adderall, Xanax. It should be assumed that any illicit drug could contain fentanyl." Of course, there's always new players. So, carfentanil, this is a tranquilizing agent used for elephants and other large mammals. And the little dose for humans is not known. Carfentanil can come in several forms like powder, tablets, blotting paper, and it can result in an overdose that is not responsive to the usual doses of Narcan. Also, carfentanil spray can be absorbed through the skin or via accidental inhalation of either droplets or powder. So it can affect EMS. Another big player, xylazine. This is a non-opioid veterinary tranquilizer. It's not approved for human use, but it's been linked to an increasing number of overdose deaths. People report using xylazine and fentanyl to lengthen the euphoric effects of fentanyl. Overdose deaths have spread west across the United States. So they started in the east and are coming west. Currently, their xylazine is involved in 20% of overdose deaths in Maryland and over 26% of overdose deaths in Philadelphia. However, the combination of xylazine and fentanyl has been found in 48 states. If a xylazine overdose is suspected, people are still encouraged to use naloxone because of the frequency with which it is used with fentanyl. Now, let's talk a little bit about the drug overdose rates over the last 5 years and how they relate to HHS Region 10. Drug overdoses have steadily risen over the last 20 years. There has been an increase in slope in the last 5 years, at the red line in 2018. Each year, the number of deaths rises and is now over 100,000 in 2021. This translates to more than 11 people dying each hour. So what is causing the increase in total drug deaths? Opioids. Opioids are the deadliest drug type. At least one type of opioid is a factor in over 70% of overdoses. And this graph shows how opioid overdose deaths parallel the earlier total drug overdose deaths. It also shows that the total opioid overdoses are due to a rise in synthetic opioids, like fentanyl, looking at the red arrow. This is new. This is why we're in an opioid epidemic. Now, Region 10 is 4 states, Alaska, Idaho, Oregon, and Washington. And as of 2021, our 4 states ranked in the middle when it came to reported overdose deaths in the whole US. From our 4 states, Idaho had the least number of deaths per 100,000 people, and Alaska had the most. You can compare these numbers to West Virginia, where more than 90 out of every 100,000 people died from a drug-related overdose, which is more than twice the rate of Alaska. If we look at data beyond 2021, we can find it on the CDC website using individual states. This graphic shows that the 12-month period in 2022 versus the 12-month period of February 2023, Alaska, Oregon, and Washington all saw an increase in overdose deaths, and Idaho was relatively unchanged. Now, these percentages can be turned into real numbers based on the population. It shows that in a 1-year period, 257 people died in Alaska, 360 people died in Idaho, 1,333 people died in Oregon, and 2,851 people died in Washington from drug-related overdose. That is 4,801 lives lost. Now, I also want to show that in 2023, the trend is continuing. Opioid overdoses are rising. This is an example of King County's dashboard with the last update July 23. You can see the total number of overdose incidents on a month-to-month comparison is significantly higher in 23 compared to 22 and compared to earlier years. But there's hope, right? We're treating more overdoses. Hopefully that means more lives are being saved. Okay, let's talk a little bit about risks of fatal overdose. Let's look at urban versus rural. And we can see, if you look at the total numbers of deaths, more people die in densely populated areas. Well, that makes sense, right? People come where the resources are. This includes drug supply and treatment resources. And also a denser population means more overall overdose events, and so more overall fatal overdoses. So for Alaska, that means more overdoses in the southern regions, concentrating in Anchorage, where 99 people died in a 1-year period. For Oregon, it clusters towards the northwest region near Portland. However, if you start looking at the incidence rates per 100,000 residents, the picture is not so clear. For example, in Washington, the cases are spread out. They're the worst in Mason County and Grace Harbor, which are relatively rural, and they beat King and Pierce counties in overdose deaths. Of note, Mason County is home to the Skokomish tribe, and Grace Harbor is home to the Quinault tribe and Chehalis Confederated tribes. These communities have been devastated by overdoses. Now, let's look at race and ethnicity. This graph shows you that the biggest group is that the highest group involves American Indians and Alaskan Natives. This includes both rural communities and urban communities. This is followed by non-Hispanic Black people, mostly in urban communities, which is twice the rate compared to rural, and non-Hispanic white people in both urban and rural communities. Now, if we look at age and gender, we can use Alaska as an example of the demographics because the statistics are similar to the general US data. 2/3 are male, and 3/4 are people ages 25 to 55-year-old, the prime of their life. If we look at Washington, we see similar trends. Males, seen in dark blue, are twice as likely to die from a drug-related overdose as females, seen in green. And all age groups are affected, with 25 to 55-year-old having the highest risk, regardless of gender. Now, who is at risk of overdose or fatal overdose? So the number one is the previous history of an overdose. So don't be afraid to ask your patients. Another big risk is the amount of opiates they're taking. If they're taking over 100 morphine milligram equivalents per day, or if they're mixing the opioids with benzodiazepines or antidepressants, their risk will rise significantly. If people experiment with counterfeit medications, their risk rises because of the poison drug supply. If there's a change in opioid tolerance, a person who's been in recovery and not using and has a life event that causes them to relapse, or a person who's been in jail and comes out and uses the same dose they remember, they're at more than 10x the risk of dying. If you mix opiates with respiratory depressants like alcohol and benzodiazepines, your risk increases significantly. And if you mix them with stimulants like methamphetamines, your risk increases significantly. So I just wanted to talk a little bit about this graph. And this is from University of Washington Addiction, Drug and Alcohol Institute for 21-22. And what you see is that synthetic opioids mixed with methamphetamines pose a significant risk of fatal overdose. In fact, 26% or 1 in 4 of all drug poisonings involved both an opioid and methamphetamine. If you look at the middle bar, which is synthetic opioids with synthetic opioids, that represents 16%, or 1 in 6 people died of an opioid alone. And that was usually fentanyl. Other big players on the side you could see is alcohol and cocaine, and they are actually involved in more overdoses than heroin. And the one thing to note here is if you look at the square and you see that alcohol combined with alcohol and that square looks white, that's actually not correct. That's a data problem because they considered alcohol alcohol deaths alone were not considered drug poisonings. So I just want to warn you that that square is probably not as light as it looks, especially in certain communities. Now, here's another example from Idaho, and the quote is of the 287 drug overdose deaths in 2020, 96 were reported to specifically involve methamphetamine, making it the second most frequently involved substance in drug overdose deaths in Idaho. And so it is really important to think of polypharmacy and to ask your patients about the different risks. Oops. Okay, so at this point, I will hand it off to Mike, who will take us through part 2.
Thank you, Desi, and thanks to ATCC for having us here. So in this second part of the presentation, we're going to talk a little bit about OD prevention education and the interventions that we're teaching, some new naloxone formulations and new devices and mobile apps that are coming to help prevent fatal overdoses, the challenges we face in adopting these new tools for our risk populations, and then we'll talk a little bit about our story as a Unimedical and how we came to develop new products for the opioid overdose epidemic. So one of the biggest issues with overdose prevention is really recognizing that the overdose is happening and the response to it. often the most challenging part of this is simply finding the patient who's overdosed. They're often located in private spaces like a bathroom or a bedroom, or if they're in a public space, it could be a public restroom or somewhere outside of view, but still in the public. Now, once you see someone who may be overdosing, the hardest thing is being able to tell, are you sure that it's an actual overdose and not simply heavy sedation? Heavy sedation from opiates can often look like overdose in terms of a lack of responsiveness or difficulty breathing. But really, it's the attempt to stimulate the patient and they don't respond, or hypoxia that can be a definitive criteria. Now, once we know the person is overdosing, or we at least think they are, the person who's intervening has to decide that they have the knowledge and the confidence to be able to do this, especially on a stranger. And that means, can they help? Do they have Narcan with them? Are they willing to call 911? And often are they willing to provide rescue breathing until 911 gets there? Now, I think we're very fortunate to have good resources in this region. This is an example from the University of Washington, where it's a pamphlet showing people what an overdose looks like, giving them very clear instructions. And I think this has actually gone a long way in recent years to helping people feel more comfortable interacting with folks who may be overdosing. Now, another aspect of this education is really having folks recognize that it's not just bystanders who respond to overdoses, and that whenever overdoses occur and EMS is sent out, that it may not just be firefighters who arrive. One of the new programs that is taking place in both Seattle and Portland is EMS-based crisis teams. Now, this will often involve a social worker going along with firefighters so that whenever they do the OD response, they can actually stay on scene. Now, that allows them to have follow-up medical care, but more importantly, help to try to navigate services intake so that person in crisis can actually be have their needs resolved by more than just medical reversal of overdose. In Alaska, they're conducting something very similar called the Crisis Now model. Now, this is where you can actually have intervention either before or after an overdose, or simply if somebody wants care. There's an 24/7 crisis call center that has a mobile crisis team staffed and ready to go out and actually meet people wherever they are. Now, this mobile team helps them navigate services with a point of getting into stabilization programs, either one-day stabilization or short-term stabilization. So now I'd like to talk through some of the new products that are available to help prevent fatal overdose. So one of the things that's happened in recent years is the number of naloxone formulations has drastically expanded. I think most providers are familiar with the 2 milligram injectable form from Pfizer, seen on the upper right. But now there's an additional injectable form really designed for bystanders. And this is called Zimhigh, and it's a 5 mg dose, IM or sub-Q. Now, this device is really designed to be used by bystanders, as you can see there on the right-hand side. It has a ergonomic configuration so that people know how to hold the device without exposing themselves to a needle, where to put their thumb to make sure that the dose gets distributed, and to make sure, and instructions on where to actually give the injection into a major muscle group like the thigh. Narcan, we're all familiar with, is available now as an RX and OTC nasal spray. And generics of this RX product are also coming out. Teva launched the first one earlier this year. There's also a generic OTC naloxone available called Revive. This is a slightly lower dose device, and it's going out there with the purposes of really addressing folks who are opioid naive and who may have accidentally ingested an opiate like fentanyl. Now, this product is actually 40% cheaper than the current price of Narcan, and their hope is to get this into basically remote bystanders, folks who will be in the community and simply carry naloxone just in case. On the other end of the spectrum, there is Cloxada, which is a nasal 8 mg dosage form. And this is really for fentanyl overdoses. It's essentially 2 doses rather of Narcan delivered simultaneously, and it comes in a package of 2. So it could get up to 4 doses of Narcan per box. Unfortunately, however, naloxone isn't really a panacea. It was most effective in the days whenever heroin overdoses were the primary driver. But unfortunately, with fentanyl today, multiple doses may be required. And in fact, fentanyl can be combined with things like xylazine or antidepressants to extend the opioid effect. And therefore, that it isn't just opioids you have to worry about reversing, but also the other compounds. Now, because these other compounds are present, it can provide a false sense of security. Often we think about opioids as the primary thing to engage in reversal, but for things like xylazine or other tranquilizers, you also have to manage the respiratory depression of those compounds. And finally, cost and availability for a lot of the people at risk are very, very high concern. One of the biggest issues with Narcan going OTC was what would the price point be? Well, even at a price point of $40 to $50 OTC for a box of 2, that's still beyond the range of a lot of folks in the community who need help. And so one of the hopes is the lower priced generic OTC Narcan Revive will be able to have a role in expanding access. Broadly speaking, though, the issue with naloxone as a reversal agent is that the individual doing the rescue has to balance how to give enough Narcan to reverse the overdose without giving so much that you induce withdrawal. And that can often be very challenging. So some of the things that have come about of non-pharmacologic ways of intervening for overdose have come in the form of wearable devices and mobile apps. So these are relatively new products. So today we're only going to talk about 4 of them, but we do hope that several more are in the pipeline and they'll be approved soon. So among the wearable devices, we're going to talk about Masimo's opioid halo, as well as our product in development, the armband. And for mobile apps, we're going to talk about a couple of different ways of using a phone to help prevent fatal overdose, both with the Second Chance app and the Brave app. It is worth noting that neither the armband nor the Brave app are FDA approved yet. So recently, Masimo approved the opioid halo system, or rather the FDA approved Masimo's opioid halo system. Now, this is the first device for opioid-induced impairment of oxygenation, essentially meaning opioid-induced respiratory depression that is severe enough that it results in oxygen levels dropping. Now, this is a fingertip pulse oximeter, as you see there in the picture, with a wrist-worn battery and transmitter, a small tabletop monitor, and then a mobile app. So this device really detects oxygenation drops, not so much respiration. But when oxygen drops, that's a relatively late sign of overdose. And so the tabletop monitor will start to alarm. Sometimes this will allow the person to wake up and self-rescue, essentially breathe and get enough oxygen back in their system. But if they don't wake up, the mobile app connected to the device will start visually alarming for bystanders and start to text user contacts for help. Now, these are contacts selected by the wearer, and they're automatically engaged in the system. Now, this is a one-way text. This is basically an emergency alert, but there's not a feedback loop to allow the person knowing or bystanders know that there is help coming. And it really doesn't have a feedback mechanism for the users, or sorry, for the rescuers to tell EMS that they're also on their way. However, this device does have a unique feature that it has a live call center that will try to reach out to the patient. And so because it's on their phone and the phone is assumed to be near them, if they can reach out to the patient, they can try to get a response, ask if they're okay, ask if this was an accident. But if there's no response, that call center can actually call 911 directly. And Masimo got approval for this as a prescription and OTC product recently. And this has a lot of advantages. Clearly, the first device that the FDA has approved for opioid overdose is meaningful because that opens the doors to others to follow. And this traditional fingertip sensor is very reliable. It can easily be removed and doesn't have a lot of the issues around skin tone that other devices have in the past. This uses Masimo's technology that they have in the hospitals, and north of 80% of all US hospitals rely on Masimo products. So it's a very reliable system. Unfortunately, that fingertip sensor, as reliable as it is not the easiest to go about your daily life with. And so having that fingertip sensor be there may interfere with daily activities, unfortunately, including opioid use. Unfortunate because it may make the person take off the device prior to use. This device really is designed for in-home use, as the tabletop monitor kind of communicates, and it is continuous monitoring. That means all the vital signs of the patient will be monitored and logged, which has privacy concerns for some folks. It's also relatively expensive at $250 a unit, but in the setting of hospital at home, this can be a great product for folks who are opioid naive and worried about medical interactions, or rather medication interactions after surgery, or for folks who are have a bystander present and who lives with them and is able to monitor that tabletop unit. So another way of using phones to protect from fatal overdose is to actually use the phone itself as the diagnostic device. And so this product, Second Chance, actually uses the smartphone speaker to send sound waves off and basically bounce off the patient as if it were sonar. The microphone receives these signals, and they developed a learning algorithm that can detect breathing. Quite neat. They were able to detect respiration rate changes and really use those as indicative of overdose. Now, they were cleared as a respiration rate monitor under a 510K in November of 2021, but they don't have any labeling specific to overdose. This technology was quite unique and was developed at the University of Washington and their spin-off company, Sound Life Sciences. And I think what was interesting is that they were able to successfully detect opioid-induced respiratory depression and apnea in opiate users. Now, these were users studied at the Insight facility in Vancouver, BC. And what's notable is that they were able to detect differences between opioid disordered breathing and opioid-induced respiratory depression and apnea. And that's a fairly sophisticated difference to make for a smartphone application. Clearly, the advantages for a system like this are its technological novelty and the fact that it did work in opioid users. It's also really nice to have a non-invasive, non-wearable option to look for respiration rate and apnea. And because it's a smartphone application that only uses a microphone, it's a very low cost of deployment. Now, the ubiquity of phones is great. It keeps them low cost. It means almost everybody will have access to one. But unfortunately, it is using a microphone. And so that phone has to be within 3 feet, and it has to be in a somewhat quiet environment. While it's not necessarily listening for breathing, it is using sonar. Other competing audio waves may interfere with it. I think most significantly, unfortunately, it doesn't work if the phone's in the pocket of the person. It has to be a set distance away for the algorithm to be able to understand what breathing looks like. And the app has to be activated. It really can't run in the background. Now, this product was acquired by Verily, the life science division of Google, in 2022, but it is not yet actively marketed. They haven't made any announcements as to when they'll make this again public for widespread use. But the advantage of apps like Second Chance is that it helps protect people from overdose when they are alone. Now, Brave is another app that also helps to use when alone, but it does so via a fairly novel approach. So it engages people to have live monitoring prior to opioid use. Now, in this way, the patient will actually call a call center but prior to use, and then the call center will stay online with them until they confirm they're okay. This is a very novel approach to safe consumption, and I think it's one that we haven't seen nearly enough of, which is users protecting each other or users going to other folks who are looking out for them with a sense of, I may be in trouble, Please watch over me for a limited time. This technology was developed at the University of British Columbia, and really it allows users to establish their own rescue plan. So if they don't want to call their contacts, but rather call EMS, this allows them to establish that prior to use, and it'll be in their file. Similarly, if they would request EMS use and transport, then it lets them set that up. Now, Brave, the company that works with this, Brave Technology Cooperative, they actually partnered with a group called Rapid SOS Ready. And this let them as a startup work with 911 and EMS systems throughout the country. And so in this way, they used a call center function to have the emergency response, but it was their own folks who were actually doing the monitoring of the patients. Now, clearly, this is a very novel approach, and it is unique in its way, but the evaluation is by trained staff. So they're there listening to folks who may be using or who are using, and they're there with them until they receive after confirmation that they're okay. And that means the patient's really never left alone during this vulnerable period. The other advantage of this is a phone feature using just the audio portion of the phone, and so it's accessible without data or Wi-Fi. And for a lot of folks, that's really important. Now, as interesting as this is, it is still fairly intrusive. It does require one-on-one human interaction prior to opioid use, and that may be a non-starter for a lot of users, or at least something that they have to take time to get used to. It can also be difficult, even for trained staff, to differentiate between heavy sedation and overdose. A person could be non-responsive, but yet not hypoxic, and not have difficulty breathing, but just simply heavily nodding off, in which case even the trained staff may feel compelled to call EMS or notify their contacts. This product is not FDA cleared. They haven't made any comments as to whether or not they'll be applying for FDA clearance. And as a startup company, there have been some concerns about their support level and the ability of the call center to really sustain the kind of interaction they would need at scale. But insofar as innovations are, this is a safe, remotely monitored form of consumption that can protect people. It's also easy to imagine this kind of a system transitioning to, instead of trained staff, but peers, in which they would, in which the user could also share their status with others. This is our armband product. I'll talk a little bit more about this later, but also in development right now. And really, we're building this overdose monitor for opioid and other drugs, and it's primarily designed as a local alarm to function independent of the phone. But when engaged, the mobile app is also designed to automatically call contacts or EMS for help. We're developing this in concert right now with NIDA, and we're in the middle of our phase 2 SBIR grant. I'd like to talk for a minute about some challenges in adopting these new tools. It's great if we can build these things and bring them to market, but if they're not adopted by patients, unfortunately, they don't have the effect we'd like to see. So what we've learned in talking to a lot of different folks is that the biggest thing around adoption is choice. So people who are at risk want to know and be in charge of who is called to help. They are incapacitated whenever they need to be rescued, and so they want to know who is going to come to save them. People trust their friends and family, and so they know and can tell us who can be relied upon to help. And that's really important because it allows them to inform us about the safest methods for them in their individual situation. People also want choices of what data is being recorded. So folks really do care about their privacy, and everything from location to vital signs. They simply don't want their data to be used against them in the future. And we'll talk a little more about social and legal penalties in a moment. But that's the kind of consequence they're concerned about. They care about where they can be seen. A lot of our folks are justice involved, and they really don't want to be tracked. frankly, no one wants to be tracked. People want to be protected, not surveilled. They want to know that if you're going to engage location monitoring, you're doing so for the purposes of rescuing, not trying to look in on other aspects of their life. People also want the choice of when to use these tools. Almost everyone in the who is at risk in the community knows when they're at risk because they know when they use. They know when they get a new supply. They know when they have been either in incarceration and released, or have undergone treatment and haven't used in a while. They know when they're most at risk, and so they know when to protect themselves. But it's our answers to these questions. It's how we support the choices of people at risk that is really going to impact adoption and make these prevention tools effective at scale. So there are multiple barriers to adoption for people at risk. Everything from their user experience and privacy concerns to what happens after the overdose, and what happens not just to them, but to the people around them. And also, how do they get access to these prevention tools? I think if certainly as medical device developers, as folks who are used to working with patients, we tend to have a one-way street when it comes to device development, which is we build products and then we find ways to convince people to use them. I think for this population, that's especially risky, because if we can instead address the concerns of the people who are at highest risk for overdose by adapting to their user experience, their concerns around social and legal issues, that's the way to have the greatest impact. There won't be one size fits all for everybody, but with folks involved in harm reduction, with folks involved in preventing fatal overdoses, we can find a means of protecting each person out there. Now, for most of us in this space, we often talk about meeting people where they're at. That means OD prevention tools have to fit into their life. And that means putting ourselves in their shoes when we ask them to please use this method. No one wants to be labeled, so they're concerned about their appearance. They don't want to be necessarily telling folks they are at risk for overdose. A lot of times people are in an altered state, and so the interface for these devices has to be very simple and easy to use. We don't want to expose people to false alarms because folks are concerned about what happens if the mistakenly goes off, not just for embarrassment, but also the legal and social consequences around that. And finally, they are concerned that this becomes something that they have to wear all the time, that this is something that is a permanent life change for them, as opposed to trying to protect themselves whenever they are most at risk. But all of these concerns fit into the notion of stigma. And the most important thing for us to understand is OD prevention tools can't further add to the stigma that these people at risk already experience. Now, these folks have real concerns about privacy for good reason. Again, they don't need any additional stigma. They don't want another ankle monitor or breathalyzer applied in their lives. They don't want us to look for drug use. We said we're trying to protect them from opioid overdose. That's really what they want to see us doing. Not looking for an excuse to bust them, as these quotes were from our interviews with patients, but really looking out for them for their life. Similar for location tracking, they really want to understand that if we're going to share their location, they know when that is, and that we don't put other people in legal jeopardy when doing so. Similarly, there's a concern with biometric data sharing. A lot of the vital sign monitoring is designed for sick patients in a hospital or patients who've just been released from the hospital. That's a very different mentality than having data shared all the time, and it can often leaving our patients feeling like lab rats, as they said. Another thing that they are concerned about is, even though our best intentions may not be followed out when it comes to 911 interaction. So concerns about police response above and beyond whatever EMS is doing still exist in a lot of our patients' minds, even with safe harbor laws. In a similar vein to that, The confidentiality of these overdose events is deeply concerning to them because of the potential downstream consequences. Now, all of these things are ways of saying we have abilities to monitor you, and we have to monitor you at some level to protect you. But the way we can do that is reframing watching you to watching out for you. The only reason we are monitoring you is to keep you safe, and we're only monitoring for things that will truly threaten your life, not just behaviors that otherwise might put you at risk. So as we mentioned, that people are concerned about the impact of sharing these OD events with others. And this is frankly, again, for good reason. There are justice consequences, legal consequences to folks if they have an overdose event, because it implies, obviously, that they were using opioids. And sometimes that can be a parole violation or worse. Similarly, people have risks about their housing being taken away or other resources taken away, simply because they call for rescue during an overdose event. Good Samaritan laws also vary, not just across the United States, but even here within Region 10. And a lot of folks we talked to were very concerned about the other people they could get into trouble, not even necessarily about their own risk of overdose or even their own risk of arrest or losing their housing, but it was what happens to the people who tried to help me. Now, all of these concerns are real, they are personal, and they're often not only patient-related, but geographically related. So we have to address these as we're rolling out these tools and try to educate folks, because these tools are only going to be used if people trust us to do right by them. Now, at the overall level of prevention, this is a public health exercise. With prescription, OTC, and harm reduction products, we now have multiple channels to reach people at risk. And there are a lot of pilot programs now at OTP sites and federally qualified health centers for new approaches. And these are funded via the settlement monies and SOR grants. But there's a real appetite out there for trying to figure out how to prevent fatal overdose. One thing that hasn't gotten a lot of attention yet is contingency management. And for prevention measures especially, this could be a tremendously helpful tool to incentivize people to wear it every day, or wear it for 12 hours a day, or wear it whenever they feel like they're going to be using. But the ability to compensate them for the number of hours that they put the device on and show them that we care about them, even if the device doesn't help them that day, it may help them tomorrow, next week, or next month. But all these OD prevention strategies have to be covered by payers if they're going to have a significant impact on the opioid epidemic. So one of the ways I thought we would end the talk here is to talk about our story as AUNA Medical. Now, how do we learn a lot of these things that we're presenting today? We had to go through the development process ourselves, and we had to go out and talk to users. So our problem to solve was relatively straightforward. 80% of the overdoses happen at home. Half the time people are nearby, half the time they're not, but everybody knows where these people are, and we know what to do to save them. If we could simply get notification out, thousands and thousands of lives could have been saved. We built the armband device as a way of having an ambulatory device so that people could wear it underneath their shirt sleeve and go about their daily life. It works inside the house, outside of the house, and inside the house, really it's designed to have a fire alarm level alert, and it's for people to wear. They don't need anything else with them. There's no remote monitoring table. There's no continuous vital sign data tracking. It's simply to tell people who live with them that they're having an overdose event. If they're home alone, we wanted to make sure people were protected. And so we do have a mobile app that is paired with the phone that runs in the background that will automatically notify contacts or EMS should they opt in if an overdose is reported and the person doesn't cancel the alarm. Here's a really short video. I apologize if it's a little choppy, but this is just illustrating the kind of ease of use we're designing. So this is a wearable strap put around the upper arm. All you do is simply open up the device, charge it, take it off the charger, put it on your arm, and go about your day. This is clearly one of our prototypes. The commercial unit we intend to have going to market will basically be about the size and shape of a Fitbit, just worn underneath the arm, and you can cover your shirt sleeve with it to conceal it. We're also looking at other locations in the body that would also provide discretion for patients if they don't want to wear it in the upper arm. We feel like this product has a lot of uses, primarily because it is for home and ambulatory, so outside of the home use, and it really is focused on opioid overdose. So this is not a respiratory depression algorithm. This is not looking at any other signs of drug use. It is purely for opioid overdose. We've been fortunate to have NIH support and have worked through the device self-adjusting for variation in skin tone. So now it can serve all populations. It has both acoustic and vibratory or haptic alarms, so the patient can get stimulated multiple ways. It also provides voice instructions so that it can tell people around the person, this may be an overdose, please call 911. As with all devices, we have our limitations as well. This is really not designed for 24/7 wear. Most people know, again, whenever they're at risk for overdose and will wear it during that usage period. It is only a 3 to 7 day battery. We would obviously like to extend that so people don't have to take it off and put it on the charger as often. But for that reason, it still does need to be charged. And while it's on the charger, clearly people might use and not be protected. The device isn't FDA approved yet, but we are hoping to launch it within the next 18 to 24 months. Just to give you some sense of where we have come from, we founded the company a few years ago, put the device through initial studies ourselves, then applied for grant funding in phase 1 and phase 2, and also received support in the form of NIH Innovation Corps, which really let us go out and talk to users, talk to counselors, talk to providers, and it was invaluable. I'll give just a brief example of this. So whenever we were going out and talking to folks, we wanted to offer the most complete protection for the person possible, including alarms, speakers, notification to their contacts, but then automatic calls to EMS, so there was no time delay. And even we have an embodiment that can be paired with a wearable injector for naloxone. So you could literally have the device on your arm and it would deliver Narcan. However, one of the purposes of going out and talking to folks is to figure out when you're right, such as they love designated contacts. Everybody thought this was a great way of solving the problem of finding somebody to help. They have to be somebody the user trusts. End of story. We also found out we were wrong about certain things. Automatic dialing of 911 simply was a non-starter for most of our users. Everyone who's at high risk, unfortunately, has had one interaction or another with law enforcement, and a lot of them still had issues and concerns about reaching out. In fact, this was confirmed by most 911 rescues don't involve transport to the hospital, and most overdoses, the vast majority of overdoses, don't get called 911 at all. So this let us really focus our efforts on getting that information to patient-designated contacts and leaving the automatic features of 911 and naloxone to others. But this was the advantage we had in both being supported by NIH, but also being told, go out there and talk to people at risk, not the people who are statistically represented in your patient sample because you have to conduct the studies for a certain medical endpoint, but really the people who are most at risk because they're the ones using opioids. And so with that, I will end and take some questions, but I just want to say thank you. And for folks who want some more information on this, there's some links on the slides. But again, to ATTC, we very much appreciate this opportunity. And we're really happy to see all these products coming forward.
Thank you, Michael and Desi. Wonderful information. You gave us a lot to think about. I tried to kind of keep track of some of the questions, and I think Desi did address a couple of them in the chat box. but yeah, and forgive me if you did cover some of this in the presentation. Someone asked, is anyone giving out hopefully I'm saying this right, Cloxito for agencies to use or to have on hand that you know of?
Yes, so Cloxato is being given out. We actually found that the other new product, the 5 meg injectable, is also being given out. I believe the company backing the 5 meg injectable is open to doing harm reduction work, and so I think the availability of the products is certainly out there. And I think I would encourage anybody to reach out directly to the companies. But we also have some contacts if anybody is looking for samples or donated devices.
Great, thank you. This one, I think they were referring to the different apps, but somebody asked what was the percentage of people that were trying the different apps, or I know you mentioned that some of them weren't necessarily fully out there yet, but what is the percentage of people using
It's
that?
not very widespread right now. So I think that the implementation of the Second Chance app, it went through FDA approval, and they showed data in opioid patients, but its label is only for respiratory rate detection. And so I think they're conducting some more trials on that now, but Verily hasn't said when it'll be out. The other program, the Brave app, is available now, and so I think that can be found online. And I think one of the comments was from their side is that because it was available online and it was available for a variety of devices, it is possible to currently deploy that without the company's permission, without any regulatory agency's permission, as a standalone service.
Great.
And I think just adding to that, somebody had mentioned that there is a never use alone phone number that can be accessed as well. Those are different companies, but they have the same mission. And so I think it's great to have more than one tool in our toolbox.
I think the last question that we had was what was the cost of the IUTA armband?
So our goal is to make this as cheaply as possible. We'd like to get down to Fitbit level cost, especially for harm reduction agencies and Medicaid. We're not on the market yet, so I can't give you a final price, but it's trying to be competitive with another wearable device. $100 more or less. It's still, I think, something where we're trying to drive that cost as low as possible, because we don't want to displace other resources. And so we don't want it to be a choice between the naloxone and the armband. They should both be available to everybody.
Those were the only questions I saw in the chat box. I'll just go ahead and say a couple of closing remarks before people start.
Jennifer, there appeared to be a raised hand. How does that work?
That's a good question.
Maybe they can just type it in the chat box.
Yeah, it would probably be better just to type it into the chat box. Okay. I'll do some closing remarks, and maybe they'll have a chance to put that in there before we end today. So please remember to fill out our evaluation survey for this webinar. It's provided up in the chat box, and we'll also be sending it out in an email within the next couple of days. And be sure to join us for our next webinar on September 6th. We're offering that in partnership with the Clinical Trials Network. And the title of that is Not Too Much, Not Too Often, and Not Too Many: the results of the first large-scale international project to develop lower risk gambling guidelines. And let's see, I'm trying to look through the chat box to see if somebody was asking what the cost of the Cloxito is. Do you have a number of that?
So I don't have an exact price on it. They, I believe, have recently adjusted their price because of the OTC Narcan. So I think it will be available from the manufacturer at a different price than the launch. Again, I would encourage anybody to contact the companies directly. They're in general very good about helping folks out.
Great. And I see that you also put your email address, Mike. Thank you for doing that.
Also as well, yes. Yeah, we would, Des and I would be happy to answer any questions for anybody, or just if you're interested in more overdose response and education, or just want to chat, please reach out to us. We always like hearing feedback.
We love working together with other groups. Yeah.
Well, thank you both for your time. We really appreciate you taking time to present to us, and thank you to our participants for taking the time to join us today. And we hope to see you on our next webinar.
Absolutely. Thank you, everyone. We really appreciate the time.
Thank you.